So the third part of our training is really a panel about how do we do better? I will inevitably ask you the magic wand question. If any of us could create anything, what do we really think we need? But the first little tidbit I want to give you, that literally I think I've learned more about in the last 3 months of my career than I did the first 30 plus years of my career. And that is, we don't shop well, okay? So I'm going to give you a common experience. How many of you have ever gone to buy a car? Okay. Were you able to get that at Bass Pro Shop? Well, why not? Why would you not be able to buy an automobile, a Chevy pickup truck, for example, at Bass Pro Shop? They don't sell them. Right? Okay. So we are bad shoppers. Okay, so let me explain this better to you. But this is really important for us to teach our teams, and you guys can be great leaders of this. Jim did a great job of explaining how certain symptoms look in our folks, and we have the DMID, which is a great reference for folks who happen to have a diagnosis of intellectual disability. But what we do is we go to the community mental health center and we say, Jill needs therapy. And they're like, well, what's going on? Well, she's autistic. She has an intellectual disability. And you know what happens? That's not what we do here. That's like trying to shop for a car at the Bass Pro Shop. What we need to be doing is going and say, wow, Jill could really use an assessment. She's lost 10 pounds. She's not sleeping very well. And she's really, really struggling to even enjoy things she used to enjoy. That would be depression, right? That's what you're shopping for. You're shopping for services at a community mental health center for mental health services. You are not shopping for services based on their primary diagnosis of intellectual disability. And I can tell you that has been one of the strongest messages we've gotten from the community mental health center system through these trainings is that we don't always present well, and so we get mad and we're turned away. Just like if you went to drive by a car at Bass Pro Shop and they're like, I'm sorry, we don't do that here.
And I think that one of the things, and you're exactly right, but one of the things that's important about this is that, the people in this room, myself included and Kelly included, the reason that I would be accompanying somebody to that appointment is because I work with people with intellectual disability or with autism. And so if you're a staff person, that is top of your mind. That, well, that's what I do, so that's what they're here for. But if you're going to therapy, nobody's going to talk you out of autism. A therapist isn't going to teach you not to have an intellectual disability. They may teach you to overcome barriers to success, and that's what everybody does when they go to therapy. And so if you're going there, what she's basically saying is be a wise shopper. You're going there and you're saying, hey, this person has these issues that are related to mental health because this is a mental health center. And the reason you're there is because they're a mental health center. They're not curing these other primary diagnoses. So be a smart shopper. Go there and say, this person's having depressive symptoms, they're sad all the time. And then they might say, well, so why is it that you're here with them? Well, they also happen to have autism, but it doesn't really matter, and I can help you kind of figure out that part of it. But what they really need is therapy for these things.
So I'm going to have these lovely humans introduce themselves. We have a panel of amazing behavioral consultants, and they're going to answer some questions for us. And, they know me, so they have no idea what's going to come out of my mouth. But I will say, Julie, you could start first and tell us who you are and where you work.
Hi, I'm Julie. I work with Kestrel Behavioral Health. I've been a BC for about 6 years, I think, now.
And I'm Gina Schenk. I'm at Opportunities for Positive Growth. I'm a licensed clinical social worker and behavior consultant. I have been in the field since 2002, coming from mental health prior to that.
And I am Patrick Jameson. I have been a behavioral clinician for about 15 years, and I work with ViaQuest, and I'm a licensed mental health clinician.
Excellent. So the first question, and I warned them I was going to ask this because we're going to dive into this with you guys as case managers. What a great audience, right? Because I think this is a really important thing. And having worked with so many different team dynamics over the time, you guys probably know there's BCs that you love working with and there's BCs that you may not. Well, we probably have the same experience with case managers. My guess is you being here and being invested, we want to work with every one of you, right? But there's a continuum of what we deal with. And so I guess the first question for you guys, and anybody can answer, how can case managers help facilitate supports for people with dual diagnosis? Like what makes a really good case manager on these tough cases?
I think it's if you can understand the symptoms and presenting the symptoms very clearly, getting others around you to present the symptoms, because we can't just simply say an individual is having this behavior. Most of the time, a therapist, psychiatrist, they're really looking for symptoms. I had to learn that myself. It's just present symptom after symptom after symptom before we were able to find some form of relief for the other person. So.
And I would say case managers could assist the supports and helping get other supports like wraparound supports for people, assisting with some of those, getting those intakes scheduled. There are some companies that do Medicaid rehab option services where if somebody has a mental health diagnosis, they can get extra services. And I think sometimes we don't think of that because we're trying to get everything done through the waiver, and it's just not possible because we don't have enough in the budget or things like that. So assisting families and people doing that, helping get intakes scheduled with different companies. Also, I just lost my train of thought. I'm going to pass it on if you have something. I'll come back to it, but I just lost my train of thought.
That's the worst thing that happens today. It still's a good day.
I'm nervous. I don't talk very well.
I think it would be really advantageous, kind of really the entire goal of this presentation is to just get a more whole picture of each specific client. I mean, I know we get, PCISPs and everything else, but there's not many times that I have genuinely heard much about the strengths of a person and like just the whole picture, because usually when I am like approached for a referral, it's, oh, well, XYZ behavior happens, but not maybe some of their other goals, some of the other success stories that they've just had part of their life. And I think that would be really, really helpful to just know that there's growth and to just clearly communicate that up front, because ultimately that could be causing turnover, like if the communication's not clear, because maybe somebody gets information, like incomplete information about a consumer, and then now they don't maybe feel like they're equipped to provide services to this individual, which might cause turnover, or then we might have issues being able to just provide staff to an individual because we're not clearly communicating everything and we're only saying the bad and, oh, well, I don't want to work with so-and-so. That sounds too complicated. So just hearing more of the whole picture, I think, would be really awesome.
I did remember what I was going to say. There are a lot of companies that have really robust HSPP services where the behavior consultants are regularly meeting with their HSPP and going over some things, especially for some really tough cases. And I know Jim had, an IPP grant where he was really identifying the best practices for that. So you all may be in contact with behavior consultants who may not have that type of relationship with their HSPP. And if you just maybe asked, hey, is this something that you could do a case review with your HSPP to see if we can, kind of get the, when you drop a water and all the rings start going out, like you're starting something, and maybe, even if they don't have that relationship with their HSPP, maybe they'll start it and they could get some good feedback from their HSPP through a case review to help that person.
The ripple effect.
Ripple effect, thank you.
Awesome. We all know that when somebody is really struggling with dual diagnosis, and like you said, they live in their reputation, right? And they're identified by all their bad days. Can you guys imagine if people got to meet you on the first day and you had to tell them about your worst possible day, and that's how they know you? It's a tough situation, but we know that the folks who are better supported by great teams are the ones that have greater outcomes, right?
Absolutely.
So my question to you is, what makes a great team?
Thank you. I have a few right now, just really, really high acuity clients that I'm working with, and the things that really stand out on those teams are just the perseverance of the individuals on the team. Constantly looking for best evidence-based practices and how they can provide supports, how we as a team can provide supports. And just not striking out and then giving up. One of the things that I had learned when I used to work in ABA years ago was if somebody's not learning something, it's not a fault of them, it's a fault of us. We're teaching them wrong. We're supporting them incorrectly. And so I think that just the perseverance and just not giving up because something has gotten difficult or one particular strategy maybe hasn't worked, that's been a game changer for some of my teams.
I would say I like the word perseverance, and I would like to add the word being curious. What you're describing is not giving up, always being curious. What else can we do? It may even be that we need to go back to the drawing board on, maybe the function of the behavior is not exactly what we thought it was. Maybe there needs to be a new functional assessment and new strategies put in place, and everyone discuss, on the team, what is working, what's not working. What I always love is when we really take the DSP's feedback and helping them understand that we are a team and that they are the eyes and ears. A behavior consultant can be there once a week, maybe twice a week if we're lucky with, certain budgets and things. But the DSPs are there every day. And so getting that feedback, what strategies are working? Being curious about, hey, if certain strategies aren't working in the BSP, it's likely that they're focused on a different function of that particular behavior that's maintaining it. And so let's figure out what else can we do. Do we need some other assessments completed?
I agree with all of that. I think primarily the key for me has been, and I've worked with a couple of you in this room, it has been true conferring with all of us as a team regarding the behavior or something that we're seeing, and we're talking through it constantly. Yeah, I love that part. And that has been amazing from the case manager to family members, to whomever's on the team. We've got to confer regarding the behavior, because typically a behavior may mean one thing to 3 or 4 different people. So if we confer what it looks like, we can maybe get down to what's going on.
So when you think of and I realize that there is no common, every day is a little bit different, and individuals we serve are different from one another. But what among teams, because I think this speaks to case management. Whenever I talk to case managers, you all are very interested in the team approach, because that's a big part of what you coordinate, right? So what would be, for an individual with dual diagnosis, what would be a common pitfall that a team confronts?
What the behavior looks like, logically speaking. I mean, truly what it looks like. I think I have worked with a couple of people where we weren't working with dual diagnosis, but we were working with someone that, say, is on the spectrum, but this person on the spectrum may have pieces of depression that works with them. We figure out how we're gonna work with levels of depression, who we should turn to, whom we should discuss regarding these pieces. So.
I also think that one of the struggles is the fact that a lot of the terminology overlaps a lot within different services that an individual can receive, especially on Medicaid waiver. I've experienced somebody, like a case manager has recommended behavior supports for an individual and explains a little bit about what they do, and they see a therapist and they work on those things with a therapist, and because the terminology kind of overlaps. And so a lot of times then I think it's just a really big struggle because terminology overlaps. We don't know where to, kind of like what you were saying, we don't know where to send people. and that definitely hurts in the long run.
I think another pitfall for people with dual diagnosis is there are prescribers that are prescribing the medications who have no experience with people with intellectual and developmental disabilities. And they often prescribe, yes, they often prescribe medications that may impact their behaviors. So for example, benzodiazepines are a lot of times prescribed on an ongoing basis for people with IDD. And those are really not meant to be an everyday medication for someone. It can cause behaviors, and then what ends up happening, instead of identifying that could be an issue, then more medications are put on board for those particular behavioral symptoms. So I think really making sure that medications are linked to a true mental health diagnosis and not being just prescribed for behaviors is a definite pitfall.
That's a really good point, Gina. And one of my previous experiences was I was the clinical director for Stonebelt, and they have a mental health clinic that includes psychiatry as well as behavior support. And it was surprising to me how absolutely upset, whether it was a psychiatrist or we later had advanced practice nurses, how really disappointed they would be when somebody would come in for especially an annual, but even a quarterly visit, and they would have a DSP there, and the DSP had just met that person and couldn't say anything about yesterday's sleep. I have no idea, I'm just the ride. And for that reason, in my agency and in the places where I supervise as a level 1 supervisor, I always encourage that the behavior clinician go to the psychiatry appointment. And I realize that doesn't always happen, and there are circumstances, but if you're going to most of them, you build that relationship. And I know that there are some people who might think, gosh, that BC just has a master's in mental health, in a mental health field. And is that psychiatrist even going to pay attention? You bet they will.
Mm-hmm.
They
Yeah.
are so happy to have somebody there who understands that person. And it's kind of, somebody made reference to boots on the ground earlier. It is so positive if the BC can go. And at the very least, as a case manager, if somebody is like having some psychiatric issues that are not being fully addressed, encourage that residential provider. Don't just send a don't just send a DSP who doesn't know this person. It will lead to I promise you the psychiatrist is not going to change any meds because some DSP said, well, I was told that they're having problems. That's never going to work.
Yeah. I think what's really interesting too is I think there's a mythical, there's a belief out there that community mental health center folks do not want to coexist with the waiver team, which we have learned a lot. That is not true. I actually just did a clinical resource team pilot project, and 2 people from the community mental health center came to the collaborative meeting and were willing to talk across all kinds of disciplines because everybody really has the same desire, and that is to help this person live their best life, right? But it helps when everybody works together. And one of the elements that we've also learned is if the individual is okay with it, I would always have the BC be invited to go to the counseling session. We are not counselors. That's not our role. We're behavioral support specialists in the community, home and community-based. It's great, though, when we can all get on the same page of what we're trying to work on in someone's life and how we can coordinate that, because you don't want one part of the team doing something and another part of the team doing something completely different.
Well, and therapy is very facility-based, and it's once a week, and it's like this cadence, and the individual may kind of say what they want to say, and it may not always translate, whereas a BC can go in and talk to the therapist and say, what are you guys working on? I mean, there are some pieces of that I can generalize to the home environment. I've never had a therapist who told me, I do not want BCs coming in here. Quite the opposite, really.
Right, yeah. So, what questions do you guys have as it relates to working with these folks who have dual diagnosis? I know that you all had, anybody that wrote down anything on that survey said, we need more psychiatrists. We need people willing to work with our folks. I think being a smart shopper is one tip I would give all teams, is that we have to make sure we know what we're shopping for. That's a really important thing. The other thing is, in my mind, I constantly am trying to figure out, if I could just tell you, if we did that, we could save Medicaid dollars, it would sell, right? Because we have people unnecessarily going to jail, unnecessarily going to the hospital, being dumped at hospitals, being put in restraints at hospitals because people don't know what to do and they don't have the resources. So who has great ideas about finding those resources? This would be a quick one.
We need a directory.
We do need a directory.
breathing directory.
I will say, and I didn't know that this existed until the IPP pilot projects and working directly with them, but does anybody in here work with Station MD? Does anybody know what I'm talking about? Okay, now, hold your horses. Don't all go there tomorrow. Station MD is a telehealth platform for psychiatry and medical services, and they specialize in people with intellectual disabilities and dual diagnosis. And they did an IPP project where they offered 24/7 dial-a-doc services for some of our folks. But Jim and I have had the chance to work with their psychiatrist, who's one of their psychiatrists. This is a nationwide platform. And we had the opportunity to work with one of the co-founders through this project, Dr. Anukat. You guys, they are amazing.
They are.
Yeah.
Now, the thing is, you don't get something that great for Medicaid rates. So they're still trying to figure out how to work it, but especially great when people are in group homes because they can build that into their per diem rate, but there is a way to do it. And I would encourage you guys to at least check it out. I am consistently trying to figure out how to make it a waiver service in my head because I think it would be so valuable. What other resource issues are we struggling to find besides? I mean, you can find a psychiatrist, but you have to find a psychiatrist that gets it, right?
Exactly.
In the back, Lisa.
I've really struggled in the past with finding emergency or crisis intervention for our individuals. It seems like when they go to a behavioral health hospital or something similar, that they're being turned away because they have waiver and they have the support team at home, and they consider that to trump the mental health piece. How do you handle that when they're constantly being turned away? You know they're in crisis and there's a genuine safety concern, and the resources that are available to someone without waiver, they are being dismissed or being told they're ineligible. How do you tackle that?
I have an okay answer for that. I mean, it's not, there's no perfect answer, of course. When I came back I was born in Bloomington, but I was gone for a number of years. I started in Cincinnati and stuff, and I went to Ohio State University for my master's and PhD. But when I came back to Indiana, I came back because there was a crisis service. And some of you might have been around long enough to remember that. It was from 2007 until 2010. And one of the things that I learned was that particularly the inpatient centers are terrified of somebody dropping off a client, an individual with intellectual disability, and never picking them up.
Yeah.
And here is an actual story. I had a really good friend, he's a psychiatrist, and he was an admitting psychiatrist at some of these centers, and he told me, he said, Jim, look, if we have a person who has schizophrenia, they might be admitted on Friday, they live in the street, or maybe the sort of transitional kind of living arrangement, they stay in for the weekend, and we are fully comfortable discharging them to the street. We're not comfortable for that with an individual with intellectual disability. And so everybody has this mythology of, what if they stay here for 12 months? Our Medicaid runs out after 2 weeks, or maybe 10 days. So here was the thing that really worked for me when I was working in crisis, and I've done it a few times since in residential services, is you talk to the admitting person and you say, I'm the person responsible, and I will make sure that we pick this person up. We only want a 3 or 4 day stay. And you start saying those words like, I'm going to make sure that, here's my number. I'll make sure that we pick them up. They're terrified of the opposite. And then they'll just they'll throw up oh, we don't take people with intellectual disability. Another thing you can do is call 988, but it's not working all that great yet. But they are invested in including people with intellectual disability. I don't know how well that's going to actually work yet, but if you talk to the admitting person or you get somebody from the residential agency to talk to them and say, we will pick them up, you have my number, I will ensure that. That can sometimes lead to an admission.
Go ahead, Dan.
I also just have a question, it kind of piggybacks off of hers. So I've had times where the team feels like a mental health evaluation is needed. They'll get the individual to the center and then the person there is like, I don't know what they're talking about, I'm totally fine. But clearly, like at home and around staff and all these other things are happening. I've also had individuals with schizophrenia who have said, I'm fine, they stopped taking their medicine. Clearly things change. Oh, I can just smoke pot and feel better, or I can do this and feel better. They want to use alternative methods.
I have friends that say that too.
But, so then, like, what do we do to, how do we support that? How do we get a counseling center to understand this person really does need to see it, even though, or needs to be here, even though they are claiming they do not?
Well, I have I'm going to put you on the spot because this is how I want people in the field to think about it all the time. What if that was your sister? And she's like, what's your name?
Danielle.
Danielle, you know, if I just smoke a joint tonight, I'm going to feel better. I don't need to be here. What would you do differently with your sister than somebody you feel obligated to help through the waiver?
Well, I have encouraged them to stay on the meds. The medicines are making you feel better. When
Yes.
you are off the medicine, then things are, your perception is changing, or things that are happening. You know, if you had cancer, you would take cancer medicine. So if you have a mental health issue, you should probably stick with that mental health medication. So I would encourage that, and I have encouraged that. I guess my current situation, because I don't have anyone with schizophrenia currently, I used to, but and that there's a whole other set of baggage because mom probably also needed services, so she wasn't a very good advocate for even being as another support for the individual. But the current situation is with a young man that is so smart, but he makes very poor choices. Like he went to his leasing office with a sword, a knife, and pepper spray because he wasn't getting the answers he needed. And then somebody said, are you afraid of him? And I said, I'm absolutely not afraid of him. What I'm most afraid of is that he's going to hack my bank account and take all of my money. But he was in crisis while he was arrested, and he's been in jail for 3 months. Finally, thank gosh, his provider, Beads, have said to jail he needs to have a mental health evaluation.
Yes.
And he is going to a facility
Okay.
until July. But he was the one that would walk into a mental health facility and say, I don't know why they keep saying, you know, I have these issues, I'm totally fine. But it was clear, like, and this is not the first time he's been arrested for having a weapon, a deadly weapon. And so that is what gets really frustrating, is that we need like some magical place, you know, that will take him and say, we get it.
Right. So I think it's really, really hard because the overreach of the settings rule has made this even more difficult for us. Not that I don't believe in the settings rule, because I will tell you that I do. I think it's very much needed. But it's not just that situation, but it's families who are like not willing to do what we know we need to do. And then some of that gets into behavioral strategies. You know, I have a very similar person I worked with for years. He's very, very well known. It's like famous for making bad decisions. Also very, very smart. And maybe. And I basically, when things were really good and we were on the meds, I said, do you give me permission to videotape you when you're not? And when we did that, treatment happened because he didn't know how would a drastic difference the meds make. Because many people, not just in our system, many people everywhere, you start to feel better and you're like, oh, I feel better, I don't need those meds, right? I'm not going to do all the talking. Do you guys have feedback on how to help with those folks who are really treatment resistant?
I was literally thinking, it goes back to something I said earlier, it's describing the symptoms. And I know that sounds repetitive, but describing the symptoms, because I have learned that psychiatrists will not hear you without hearing key words, describing the symptom, what time, when, how. Is it twice a day, 3 times a day? What was the person doing before? Describing the symptoms.
As much detail as you
Yeah.
can provide.
And I do think we all need, all of us can benefit from more education on the difference between behaviors and psychiatric symptoms.
Yes.
Because you can look at something and make an assumption that it's behavioral when in fact it's tied to an assessed mental health diagnosis. And so I think that is a big gap, especially for folks with dual diagnosis, that the whole entire system could learn more about that, including our community mental health centers.
Yeah. I was going to say, in the situation where someone, starts to do better, they're on their medications, they're stable enough to have a conversation about different types of administration of the medication. There are different types of medication that the psychiatrist can look at, a shot or things that will last longer, and that there is a very clear plan for who is taking the person to the appointment, and making sure that there's not those dips where just a daily medication could be easily, you could cheek a med or just, they have the right to refuse medications. But when they are clearly stable, making that decision to look at a different type of administration, talking to the psychiatrist about that because of this issue is something that could be done.
That's a really, really good point.
Yeah, I was going to say that's very similar to what I was just going to say, which is trying to allow our clients as much control as we can, because there are so many circumstances and variables in which they do not have control over. And so, yeah, if it's something just as simple as such and such is going to take me to my appointment for my medications, or I'm going to get an injection versus taking something orally, like giving those opportunities for control goes a long way.
And even saying, like, who would you like to have take you to your appointment?
Yeah, allowing choices,
So I had a really interesting conversation with the ADA director of the Department of Corrections recently. And there are a number of people with intellectual and developmental disabilities and co-occurring mental health challenges across the state incarcerated. And we were talking about the rate of return, recidivism. And he said something so profound to me that I think I might have cried. I was like, well, that's terrible. But it's really good for us to think this through. He said, many, many people want to come back to jail because they have more freedom while they're incarcerated than they do in their waiver home. And that gives me goosebumps to think about, because some of the behaviors that we observe and some of the folks who really aren't treated well with true mental health challenges, they are really pushing the envelope to get us to listen to them, right? And it becomes a real challenge. You had a question over there?
I think something just personally with my case that I've noticed a lot since I've started working in this field is, and it could be my county, because it's Madison County, and there's just not a lot there. And there's a lot of small towns, so it could just be the mindset as well in that area. But I've noticed a lot like the preteen and teens. My parents of those kids have a lot of struggles identifying what's a symptom of their diagnosis and what's teenage behaviors and what's actual mental health problems. And so I have 2 definitely that I can think of off the top of my head that are, one's a preteen, one's a teen about to go at the end of his high school career. And both, I have had them both for pretty much my whole time as a case manager, and I have every meeting sent them resources and tried to encourage them to at least just try behavior management, because I think that these, like one of them has cerebral palsy, and like there are behaviors happening at school and at home with siblings that they just put on his diagnoses. They don't try anything.
And they're just being high school kids.
But he's like wheelchair bound.
Sure.
So he's not as verbal as everybody else. Obviously, physically can't do what everybody else can do. And I'm not saying the parents don't do a lot, but they have 4 or 5 kids. So it's like, he needs someone else on his team. Someone that takes him to do things or watches how he behaves and can identify a problem. Because I'm sorry, as a parent, when you have 4 or 5 kids under preteen age and a newborn baby, you're not paying attention to what your child with cerebral palsy, what the root cause of that behavior is. And then the other one's obviously like an older teenager, and he's adopted. So the parents, they don't want to try a behavior consultant because they think these are behaviors of trauma.
That's why you need a behavioral
And that's exactly
Yeah.
what, and I try, so I guess my question is, sorry for being so long there, is like how can I just encourage families like that to, because I really tried.
It's really hard with parents, and I'm just going to give you a resource that's coming. You're going to be so excited. It's hard because parents feel guilt if it's their kid, whether adopted or not, is having these behaviors, like it's a reflection on them. Many people have said, a couple over time, we need a one-pager that says what behavior supports is, right? We also need a quality guide for behavior support services. And guess what? They're both coming. I've actually been working on both of those things over the course of the IPP grant. So, and if you want me to, I'll give you a one-pager that you can look at and give me feedback on, because I think parents need to understand behaviors aren't bad. We're going back to the beginning of the presentation.
And that's kind of where I was at. I was like, I know that
People want to be happy, and how cool is it to have somebody come in and help this person live their best life?
That's part of why I think it might be also my county. There's a lot of small towns, and the mindset there might be a stigma against getting help.
One thing you might also consider too is if there's a behavior consultant who's on your caseload who you like and you think does a really good job and is liked by families, you can ask the family, is it okay if I invite this person in? And granted, they're not going to be able to bill for that hour or whatever, but to have that person come in and just demystify what it is. Because if you have somebody who's got some experience, they can kind of say, well, this is what it looks like when I come in, and here's what it doesn't look like. And it can really, the parent may have built a bunch of things. I mean, one thing that I've noted about human nature, if there's something you don't know very well, you don't fill in the gaps with a bunch of wonderful things. You fill it in with a bunch of negativity and things that you're afraid of, right? So instead you can have somebody else fill those gaps with, like, here are the good things that you can have, and especially if you think that these two individuals could benefit from behavior support, having somebody who does it describe it might make a
It's
difference.
like 2 totally different reasons. Like one's transitioning into adulthood and they're just a little immature, and I just think that having someone to help them grow into that adulthood role would be wonderful. And then the other one, like I said, it's mostly just, I think, behaviors that kids often do.
Yeah.
And I think that sometimes the story that case managers tell really impacts, right? You'll have people like, well, that's a really expensive service. You know what's really expensive is when you don't have a behavior support person that's doing good things, and you have to do 3-on-1 staffing because this person's, really, really struggling. And I think
loses a
presenting it,
placement.
if we are presented in the paradigm shift, as we're going in to help people be more happy and to help parents know how to recognize that and to come in with strategies that's going to make everybody's life better, it's different than, they come in and fix people's bad behaviors, right? Okay, I'm going to finish with one question. I can feel you getting wiggly.
I know it.
And you guys, because you're supposed to only be here till 4:30, I'm saving 4 more minutes. You guys get to go first. If you had a magic wand, without regard for money or service definitions or policy, what's the one thing that you could help fill this gap?
A living, breathing directory of the companies that provide services, psychiatrists that provide services for Medicaid waiver. A lot of times I just feel like we just don't know what's around, and so Yeah, that'd be amazing.
All right, Gina.
I think I should go last because I'm kind of cheating.
Okay, go ahead.
I
Oh,
just-
Lord.
Yeah, I'm cheating. I know what I really, yeah, never mind.
You know what you really want.
Yeah.
I would love to merge what mental health looks like with what we do in general in this field. When you brought up something that I thought was interesting earlier was parents who often do not understand where the disability is sometimes as parents, and then what is a typical teen behavior. Most people don't always understand the stages of development. The
Sure,
stages
yep.
of development. So
Yeah.
that's always tough.
Gina?
So I was a part of the IPP grant that Kelly has mentioned, and one of the things that I was so excited to be a part of was the crisis response team. And I think if the state were to allow us to have more access to a crisis response team for folks that we are talking about that we just don't know what to do, having some people who are highly trained in those areas and be able to come in and help the team, that's my magic wand is if we get to really do that for real. Like,
For real?
I mean, we've been doing it for real, but like the state actually says we're doing that.
How
I
about in
will after we
perpetuity?
stop, because I will tell you more about it. Okay, 3 case managers. What's your magic wand? What's your magic wand moment? What could you do?
I think we have individuals who are working with our people that either understand the disability side or the mental health side, and not both.
You are
That's the biggest issue.
1,000% correct.
Have every medical provider and team all in the same room to discuss the individual.
Okay.
Yeah.
Pay an education for DSPs.
Yes.
That's what I was gonna say, getting DSPs to understand, like.
Off the
outside-
couch, speak English,
Pay
get
an
engaged.
education for that.
Yeah.
Off the phone. Right. Well, yeah, and there's really we're in this room and we have that great idea, but how do we make that happen? So there is an IPP grant about that too.
So give it up for our panel.
Yes, thank you guys
Thank you.
so much. So, and I say thank you to you guys for being here. It's an investment of time, and your temperature regulation system and all the things. Big thanks to Butler for hosting us, and thank you so
Absolutely.
much to DDRS because this is something we haven't had. This kind of open dialogue around tough things, and Jim and I both really appreciate your time. So give yourselves a round of applause as well.
Yeah, thanks for being here.